In a lot of American towns, the single richest institution isn't a bank or a tech company. It's the hospital. It occupies prime real estate, employs more people than anyone else, sits on billions in investments, and pays its chief executive millions of dollars a year. And it pays little or no tax on any of it, largely exempt from income tax, and in most places from property and sales tax too, because legally it's a non-profit charity. How does an organization that calls itself a charity end up among the wealthiest institutions in town? The answer is one of the strangest bargains in American healthcare, and to be fair, one with a real mission tangled inside it. Start with the setup. About 58% of American hospitals are non-profits. In exchange for a promise to benefit their community, they're exempt from federal and state income tax, and in most jurisdictions from local property and sales tax, and they can borrow money cheaply through tax-free bonds. That's an enormous permanent subsidy, and many of these non-profits have used it to accumulate real wealth. Gleaming towers, huge cash reserves, Wall Street portfolios. The deal is simple in theory: skip the taxes, serve the community. The fight is over whether, for a lot of these hospitals, the second half of that bargain still holds. So let's answer it like an operator. How did tax-exempt charities become some of the richest institutions in town? The story runs through a tax bargain with no enforced flaw, a definition of charity that's stretchier than you'd think, and a genuine safety net mission that makes the whole thing hard to judge cleanly. One note before we start: this is how the finances work, not a claim that non-profit hospitals are villains. Many are lifelines. Let's follow the money. Here's the number that started the whole debate. In 2020, the total value of the non-profit hospital tax exemption, all those skip taxes and cheap loans, came to about $28 billion. Most of that is federal income tax, but the piece a town feels most is local property tax, money that would otherwise fund its schools. Now, the law doesn't ask hospitals to repay that break in free care alone. It asks for broader community benefit, which also counts things like Medicaid losses, training doctors, and research. But on the narrowest, most visible slice, charity care, free or discounted care for people who can't pay, those same hospitals spent only about $16 billion. The industry says charity care is too narrow a yardstick, and they have a fair point. Critics say a tax break bigger than the free care is still worth asking about. That gap is where the whole fight begins. So how much charity does a non-profit hospital actually have to provide? Here's the twist that makes everything else possible. There is no minimum. To keep its tax exemption, a hospital must show it provides community benefit, but the IRS has never set a required dollar amount or percentage. Running an emergency room open to all, having a community board, treating Medicare patients, these can count. So the bar a hospital must clear to keep one of the most valuable tax breaks in America is essentially undefined. When there's no floor, the amount of real charity varies wildly from one hospital to the next. One analysis tried to put a scoreboard on it. The Loan Institute, a health policy group that leans toward reform, so weigh it accordingly, compared each non-profit hospital's tax break to what it spent on charity care and community investment. By their count, about 80% of non-profit hospitals spent less on their communities than their exemption was worth. A combined gap they called a $25 billion fair share deficit. Now, the hospital industry sharply disputes this method. They argue it leaves out big categories like Medicaid losses and training doctors. That fight is real and unresolved. But even the disagreement tells you something. Nobody can agree on whether these charities are giving back what they get. And here's the finding that flips the intuition. If non-profits are the charitable ones and for-profits are the greedy ones, non-profits should provide more free care. In one peer-reviewed study, they provided less. Non-profit hospitals spent about $2.30 on charity care per $100 of expenses. For-profit hospitals spent about $3.80 more. That doesn't make for-profit saints. And one honest caveat: this counts direct charity care only, not Medicaid losses or the other community benefit the industry counts. Even so, on the simplest measure of free care, the non-profit label turns out to be a weaker predictor than you'd assume. The tax status and the charity have quietly come uncoupled. Where does the money that isn't going to charity end up? Some of it is visible at the top. The best-paid non-profit health system executives earned between $17 and $33 million in a single year. Pay that rivals public company CEOs at organizations that owe no taxes. Boards defend it as the price of running a multi-billion-dollar operation, and the pay is at least disclosed publicly. But it sits awkwardly next to the word charity, especially when much of the surplus funding it comes not from treating patients, but from the hospital's investment portfolio. This is where the richest thing in town stops being a figure of speech. Take a pure hospital system, not an insurer, just hospitals. In 2023, the Cleveland Clinic posted a surplus of about $911 million. And much of the lift came not from treating patients, but from its investment portfolio, stocks, bonds, and real estate, throwing off returns like a university endowment. That's the quiet truth about the biggest non-profit systems. Alongside the hospital, there's an enormous investment fund. Now, be careful with any single year. Those returns swing hard, and in a down market like 2022, many of these same systems posted investment losses. But across good years, the pattern holds. The surplus that builds the towers often comes from Wall Street, not the ward, and it's untaxed because on paper, they're charities. And the gap between the label and the behavior can get ugly. In Washington state, the Providence system agreed to refund or erase roughly $158 million in patient bills after the state attorney general accused it of steering low-income people into payments instead of the free care they qualified for. In Tennessee, reporters documented a non-profit, Methodist Le Bonheur, filing thousands of lawsuits against patients over unpaid bills, including against its own low-wage employees. And national reporting accused the Bon Secours system of leaning on a struggling neighborhood's hospital and its access to the federal 340B drug discount program to help bankroll wealthier locations, allegations the system disputes. These are specific documented cases, not the entire sector, but this is what non-profit looked like on the ground. Now, in fairness, there's a real case on the other side, and the hospital industry's own trade group, the AHA, presses it hard. Weigh that the way you weighed the reform side. But here it's not just spin, and the neutral numbers back a lot of it up. Government insurance, Medicaid especially, frequently pays hospitals less than it actually costs to deliver the care. That's a MedPAC finding, not an industry talking point, and non-profits swallow a large share of that loss. They also absorb most of the country's uncompensated care, the bills that never get paid at all. Many are the only hospital for 50 miles, keeping an emergency room and a maternity ward open in places no for-profit would touch, and they quietly fund things that don't pay for themselves, training the next generation of doctors, research and standby capacity for the day a disaster fills every bed. The tax break exists for real reasons. The honest question is whether every hospital taking it is actually doing this work. Because the sector is not one thing. The image of the cash-rich non-profit is real, but it's top-heavy. It describes the giant urban systems, not the median hospital. Out in rural America, roughly half of hospitals have been operating in the red, and a wave of them have closed outright. These places aren't hoarding billions in a portfolio. They're one bad quarter from shutting the doors. So when someone says non-profit hospitals are rich, the accurate version is narrower. A relatively small number of large systems are extraordinarily wealthy, while a long tail of smaller ones are fighting to survive. Averages hide that. The wealth is concentrated at the very top. So what's being done about it? Slowly, the rules are tightening. A federal regulation known as 50-1R now requires non-profit hospitals to check whether a patient qualifies for financial assistance before hauling them into aggressive collections. A handful of states, Oregon and Illinois among them, have gone further and set an actual minimum for community benefit spending, turning the vague promise into a number. And reformers on both sides of the aisle are pushing the logical next step: tie the tax exemption directly to a floor of charity care so a hospital that gives back little keeps less of its break. The through line is simple. For decades, this was a bargain with no minimum. The fight now is over writing one down. So here's the whole thing on one card. The deal: a hospital calls itself a non-profit and skips the taxes. The catch: for most of the last century, almost nothing set a minimum for what it had to give back in return. The reality: the sector splits in two. A handful of investment-rich giants at the top, and a long tail of hospitals barely staying open. And the main reform proposal on the table is to tie the tax break to actual charity, so the label carries a flaw, a change the industry resists and reformers push. Right now, non-profit is a tax status. Whether it's also a promise depends almost entirely on which hospital you're standing in. If you take one thing from this, make it this: non-profit is a tax status, not a guarantee of generosity. Some hospitals wearing that label are exactly what it implies: lifelines for communities no one else will serve. Others sit on billion-dollar reserves, pay executives like Fortune 500 chiefs, and, in the documented cases we saw, have chased poor patients for money they didn't owe. Both are technically charities. What no one can point to is an enforceable flaw that separates the two. And for now, almost nothing in the system forces you to be able to tell them apart. So the next time you drive past a hospital's gleaming new tower and see the word non-profit on the sign, you'll know what it does and doesn't promise: an enormous tax break and a community benefit pledge that ranges from a genuine lifeline to a technicality. Next time, we look at another label that quietly moves millions of dollars: what it actually takes for a hospital to call itself a trauma center, and why that designation is one of the most expensive words in medicine. For more on how the system really works, visit shanewelter.com. I'll see you in the next one.